I'm going to be speaking about the 2021 E&M guidelines, and I know that y'all have had several presentations yesterday. I feel bad that I was unable to listen in and attend those sessions, but the E&M guidelines, E&M revisions have been really several years in development, and you'll see throughout the presentation, I'm going to leave plenty of time for questions at the end. You'll see that really the essence is to return clinical documentation to the physicians. Now, when I say physicians, that includes non-physician practitioners and other qualified healthcare providers, but I'm going to just say physicians because it's easier than saying 20 words to express the same sentiment. So what the E&M guidelines in general have done is they've gone away from putting eggs in a basket, adding up a number of points and assigning a level of service. You'll see throughout the presentation that the AMA and CMS have developed a sequence of documentation rules that allow us physicians to document clinically how we're managing the patient and what's involved in taking care of the patient. And as we all know, that's really what we do. Before I go, that's fine to be on the disclaimer slide, that's fine. But before I go any further, I do want to say that I've always said since I went in practice in 1990 that the essence of coding and billing is that the provider, the physician, documents what he does and then bills for what he documents. So what I mean by that is those things that are involved in taking care of the patient, and also those things that if you're out for a day or you send the patient to a consultant or somebody else takes over care, those things that are needed for that doctor to pick up and start where you left off. So document what you do and then bill me, Medicare, for what you document. So this is a disclaimer slide. We'll get started. This is a disclaimer slide that says that things are up to date as of the presentation. As we all know, Medicare changes very frequently, and today's presentation is up to date as we humanly could be when we send in the slides. So we can go to the next slide, please. So the new revisions basically eliminate the history and physical as elements for code selection. I'll be very clear that there's going to be a differentiation between code selection, i.e. a level of service, versus documentation for coverage. In other words, if there's an LCD that says certain things have to be documented in the medical record for that procedure to be covered, that has to be documented for coverage. But for code selection, history and physical are not required anymore. The other thing that's important in that is history and physical is not required for a code selection, may be required for good care. Remember, we still take care of patients. The people on this call take care of fragile patients, people who are in pain, who need your services in order for them to return to some sort of normal lifestyle and to be able to function properly. History and physical is very important. How else can you tell the etiology of a pain, right? So what this is saying is for code selection, history and physical are not required. However, in my opinion, this is not CMS's opinion, this is my personal opinion, history and physical are the foundation of the visit. I was trained in the old days where the person who taught me how to do physical diagnosis said, if things don't seem right, take a history. If they still don't seem right, repeat the history. If they still don't seem right, things aren't fitting together, do a physical. So history and physical are very important for the care of the patient, but they've been eliminated as elements for the code selection. The next thing, major revision, is the physician chooses whether or not they want to code or bill based on decision-making or total time, not both. You make a decision which one you want to do, and we'll go through that a little bit throughout the presentation. There's also modifications for medical decision-making criteria, 99201, the initial visit lowest service level for office was deleted. And there's a different, a shorter version of the prolonged services code than the first iteration that came out. Next slide, please. So as always, anyone who has ever heard me speak about anything, medical necessity is the overarching criteria for any service that's provided. And this slide says that. So in shorthand, medical necessity, you can read the IOM, you can read a lot of different documents, but really medical necessity evolves around the right service provided to the right patient by the right physician/provider in the right frequency and with the right level of care. In other words, if a patient's being seen every 3 days for a particular problem, a 99215 every 2 days, even though it may be templated, may not be medically necessary. So it says here in the middle, I'll read it for emphasis, the volume of documentation is not the influence upon which the level of service is billed. So in the old days, with the templated medical records, all set at level 4, 99214, we all know that's what that level of service was set at. We'd get 99214s every 2 days. Well, the social history, family medical history, surgical history, they just don't change that frequently. So those elements really are not medically necessary to be put in the medical record. Next slide, please. Here's a comparison slide. Again, those of you who haven't heard me speak before, I don't read slides. I will emphasize certain aspects, however. So this is a slide that basically shows, office and outpatient, as well as others. And others, such as hospital visits and things of that nature. And those didn't change. Really just the office and outpatient services changed. So you can see this is a comparison not only of the different places of service, but also really compares prior to 2021 and 2021. And you can go through this on your own. But the key component is, and we'll go through this very frequently throughout this presentation, is look at the column that says office or outpatient services and the row that says MDM elements. And the key phrases, I'm just going to read the phrase, right? Number of problems addressed. So we all know in templated services, you can hit a dot phrase that says PMH, past medical history, or dot problem list. And all of a sudden, a problem list with 400 problems pops into your medical record. Well, unless you address every one of those, you can't count those up. In the old days, number of chronic problems, number of acute problems, all were added up as eggs in a basket, and a level of service was determined. The new E&M guidelines, AMA descriptors are number of problems and complexity of problems addressed. Okay, when it comes to data, you have to review it and analyze it. You just can't say chest X-ray obtained, MR obtained, and say MR obtained showing, interpreted by the hospital as saying such and such. It doesn't mean that you have to do a detailed description, but you have to show in your medical decision making how that information is synthesized and included in the care of the patient for that day. All right. When it comes down to risk and morbidity, it really deals with patient management. What risk of complications, and for what y'all do, injections and different procedures, the complications are real. I think that there's very few complications, but they're potentially real. So how are those complications not only explained to the patient, but how do the complications go into your decision making? For example, if someone's a very brittle type 1 diabetic, do you do steroids frequently? Again, I'm not an interventional pain physician, so I don't know the answer to that, but I know I'm an internist, so I know from a diabetic care standpoint, when a patient gets a big slug of steroids, it affects their blood sugar. So again, these are the complications that you would have to, again, we're not looking for a novel, but you'd have to somehow put into your decision making, I'm aware the patient's a diabetic, The dose of steroids I'm giving in my clinical experience show that it will not significantly impact their blood sugar control, but they're to contact their endocrinologist to make sure that their control is tightly managed. A sentence or two like that tells anyone that looks at that medical record that there is a complication risk, and you not only addressed it, but you managed it. You're not going to adjust the insulin dosing. That's not what you do. But you advise the patient to get to their endocrinologist knowing there's a potential that the blood sugar could rise after the procedure. So again, for medical decision making, it's about addressing the problems, analyzing and reviewing data, not just ordering it and saying that it was ordered or done, but also understanding the risk and how it impacts on management. Those are very key components that we'll visit and revisit throughout the presentation. Next slide, please. Again, effective January 1st of this year, you decide whether it's time or medical decision making. Next slide. What about decision making? Okay. So this is a slide. Again, I'm not going to read it per se, but I'm just going to go through key points. So, a typical office visit does have a medically appropriate history and physical. It's not required, but it is a common feature of an office visit, right? Okay. The extent of that history and physical is not involved in the selection of the level of service. I've said that multiple times. Okay. One element that's important to remember is the number and complexity of problems that are addressed. Okay. So symptoms can cluster, as we all know, but the key is, what are you addressing at that visit? That's really the key take-home message in decision-making. Next slide, please. Again, these are bolded. This is right out of E&M Services presentation for the AMA. That's on their website. You can pull it up for yourself. But when I listened to that presentation and listened to the FAQs, and we developed our presentation that we presented several times already, these are the keys, right? The bold words. Problems that are addressed. A long problem list is important in the old days of complexity of the patient, or it may be even involved in today's world with complexity of the patient. But you can't count up, there's 20 diagnoses there, unless you address each one of them at the encounter. There'll be some of them, such as diabetes, that you're not going to manage, but it does change the complexity of how you address and take care of that patient. So if you address them and it's part of the patient management, then it's involved in the decision making. If they have hypertension and you don't do anything in regards to hypertension, no comment about the hypertension other than it's a dot phrase from your electronic medical record, it's not counted. Okay, so amount and complexity of data to be reviewed and analyzed, and the complication rate. Now, there's going to be a slide coming up here, but I want to preview it, that discusses complexity. Now, I told you up front, I'm a board certified internal medicine doctor, right? And most of the people on this call are board certified or otherwise involved in interventional pain management. So the complexity of a patient and the risk of complications and things of that nature is very different for you than for me. Radiculopathy, the definition is the same for both of us, but the management and the description and how I handle it is very different for you versus me. So you see radiculopathy and back pain and things of that nature, neck pain, all these different things every single day, multiple times a day. Even though I may see functional back pain, a couple of times in a practice day, it's not really the gold standard, the gold practice complaint in my practice. So, I'm mainly diabetes, hypertension, strokes, cholesterol, things of that nature. So, for me, something may be very complex. For you, it's bread and butter. So, the complexity, so to speak, is in the eyes of the beholder. And if it is something that's very complex to you, that needs to be explained in such a way that anyone who picks up that chart to review it, including a consultant, or if I sent you the patient, for me to understand why this patient's just not a simple back pain. What makes it more complex and harder to handle and deal with the patient's problems. Okay, next slide, please. So here's some examples, right? So acute, let's look at the uncomplicated thing first, right? So this is a short-term, low risk, and something such as allergic rhinitis, a simple sprain, something like a urinary tract infection. This is something that comes in acutely. It's not complicated, really, in anybody's viewpoint, and it's something that's going to go away quickly with the proper care. Stable chronic, again, it's something that's going to last about a year or until the death of the patient. Again, most of what y'all deal with are probably things that are chronic because the primary care doctor may have already tried to take care of it once or twice. But they are people that come to you primarily. So these are things that part of your history and physical. Again, it's not part of the scoring, if you will, but it is part of the thing. How do we determine if this is a chronic illness, right? You'd say the patient's had back pain for 3 years, okay? And without my intervention, right? Without my intervention, it's going to continue to be that way. So throughout this little slide here, things are defined such as stable, right? This is something that a patient is, has been taken care of. There's no fluctuations. They're in good shape. I'll use hypertension as an example. They come in, the blood pressure is, 122 over 76, and it's been that way visit after visit. So that's a chronic, stable issue, right? Morbidity without treatment is significant because of the concern that it could become unstable. And these are things like BPH, cataracts, non-insulin dependent diabetes. To be quite frank, we probably should have added some interventional stuff here for y'all, pain management stuff. This is the patient, that has chronic stable disease. They come in, you give them your therapy, and you want to check them back, over time to make sure they're not having any exacerbations. And it's a chronic stable problem. You need to see them. If things become unstable, they all of a sudden shift into a different decision-making category. But chronic stable is something that you, through your skill set, have control of the patient, and they're no longer having significant problems. Okay, and I'm sure there's questions on that. The CPT guidance goes into a variety of other scenarios. I'm sure your presentations yesterday went into more detail. That's more case specific for your practice, but that's really the general information. We can go to the next slide, please. It deals with time. Again, you use these codes when using time. It's the total time of the encounter, right? And in the old days, remember, you could only use time if greater than 50% were used for counseling or coordination of care. In today's world, 2021, you use this whether or not counseling and coordination of care dominates the service time, total time. If you spend 45 minutes with a patient and 5 minutes are spent counseling and coordination of care, that adds into the 45 minutes, right? It involves a physician, other people in your practice, healthcare providers, face-to-face and non-face-to-face. Let's say you're seeing the patient and you say, I need to call your, the orthopedic surgeon that you saw, or I need to call your primary care doctor, your endocrinologist. Let me go call them real quick because I need some information that's germane to how I'm going to manage your case today. And you step out and answer that phone call that your staff got for you. You go out and call the doctor yourself. You ask them the questions coming in. That's counted in the total time of the care of the patient, all right? And only 1 minute per person, is allowed. So those is 3 people taking care of the patient, intermittently during that visit. You only count up the total time for the conglomerate or the totality of the time, not each particular provider. So you wouldn't bill 3 office visits. You'd bill 1 for the total time. Okay, next slide, please. Again, I am not going to read this, but this is basically some of the things that are included in total time, right? Reviewing separately obtained history, medical necessity exam, ordering medications, tests, or procedures. A lot of that's done right at the bedside with electronic medical records with meaningful use. The nurse or someone may have set it up, but the doctor oftentimes in many practices will hit the final button to send it to, the e-prescribing pharmacy. So all those things count up into the amount of time. All right. Now, one point that always is talked about is independently interpreting results and communicating results to the family caregiver, the next to last bullet point. What does it mean by independently interpreting results? What that means is, let's say, I'll try and make it as case specific as possible for interventional pain physicians. Let's say that an MRI is obtained at an outside facility, right? I can almost guarantee that, each one of you will not only look at the report, but I can almost guarantee 100% of the people in this call will look at the MRI itself, because that's really your expertise, is looking at data, looking at films, and determining for yourself what the best intervention or best course of treatment and care should be. So what that would be, it doesn't necessarily mean that you have to give a whole long interpretation, but there should be something in there. I personally looked at the MRI, and if you say I looked at the MRI and I agree with the report, I mean, is that really interpreting anything? Is that really adding to the management? There's a debate on that. You would say, yes, I looked at it independently and I agree. I would want to be very honest, to be clear in any kind of documentation, which we all strive to be. And I'm going to present a case of the most clear, is there should be a statement. I independently looked at the MRI, and I also see encroachment on neuroforamina causing the radiculopathic pain. In other words, what did you see, and how does it deal with management of the patient? Make that link. The radiologist is not going to make that link, right? Because they are clinicians in some sort, but they're not a clinician taking care of and putting into operation the care of the patient. Now, when I say that, I'm not talking about an interventional radiologist who may be doing their own injection. I'm talking about the pure radiologist that examines the film and interprets it and gives an opinion as to the diagnosis or findings on that film. So when I say they're not going to be doing a clinical follow-up, or they're not going to be intervening to address the problem, that's the scenario I'm talking about. So if there's an interventional radiologist on this call, I'm not saying that you can't do the intervention. I'm specifically saying that what you did was interpret the findings on the film and put that in your document. For the interventional pain physician, I would want to see, again, is this written anywhere? I don't believe so. It's probably in at least one scenario. But, I know in our FAQs, we have a scenario similar to that. And the AMA also has some FAQs similar to this. But what I'm trying to do is instruct you on the clearest methodology of documenting in your chart and independently interpreting results if linked with management of the patient, which is really what you're doing in your brain. If you put it down on paper, that makes it clear that even though the radiologist also said there's an encroachment on the neuroforamina, you are applying that clinically to the management of the patient. And that's really the ultimate documentation style. Again, I'm speaking level of service. I know there's a question about, documentation for coverage. And in that case, the LCDs on interventional pain management all deal with certain documentation that have to meet certain criteria in the LCD for coverage. But for a level of service, anytime that you can link any kind of an independent data analysis to the care and management of the patient, it eliminates, any possibility of doubt from entering into that evaluation from an outside source, looking at that medical record. So again, we're going to answer questions here in a little bit. Just wanted to make sure that I was as clear as possible at this point on that. Next slide, please. Simple slide. 201 is no longer available, and is rolled into 202. Next slide, please. All right, prolonged services. The old code was 99417. Do not bill that. If you bill that, it's not payable, right? The CMS has instead given us a G code, G2212, which is for prolonged services. It's an add-on code. Now notice very carefully what you add that on to. You don't add it on to a 212 or 213. You only add it on to the highest time-related level of service available to you, such as a 205 and a 215. Okay, why is that? Well, because if you're coding a 213 with an add-on code, if you're doing time-based billing, you would just bill a 99214. So you got to max out the time before you do any additional 15-minute coding. And if we go to the next slide, we have a graphical representation of this. So next slide, please. Okay, thank you. So if you look at a new patient, right, 99205, again, total time, if that's up to 74 minutes. So if you do 89 minutes, let's say 90 minutes just for math purposes, that's 16 additional minutes. You would do a 2212 times 1. And you see this represented here. So you have to max out the time-based code, whether 205 or 215, before getting involved in the extended time code G2212. I think it's very clear, and I know you won't believe this, but I'm telling you it's true. We all the time get prolonged services codes added onto highest level codes. And the 2020, the prior to 2021, maybe I could understand that because, it was a different type of level of service calculation. But if it's a time-based code, it should be fairly clearly understood that you don't add anything on until you maxed out the time allocation in a 205 or 215. Okay. So next slide, we have on our website under the E&M 2021 banner on our website, frequently asked questions. Like I said, I've given this presentation. This is now the third time, and we've had at least two, I think three separate webinars just answering questions, and we have close to or around 100 FAQs on our website. I've pulled some of the more frequent ones to go over today, and I would invite you to go and look at the FAQs that are there. Also, if you have questions in the second half of this presentation that I am not going to speak to, there are email addresses for you to send in your own questions, and we will answer them. If you ask questions today, which I'm happy to entertain, there may be some that I am unable to answer, and that's fine. I'll tell you I can't answer it because I don't know the information or I have to research it. But I've always told people the best way to get an answer that you can use for your own internal education, or if we were to adjudicate a claim against or in a separate way than what the answer I give today would be, the best way to have the answer that stands up, so to speak, is to get it in writing. So again, I'm happy to answer questions today, and I will do so to the best of my ability. But if it's something that's beyond a spur of the moment answer, or if it's something that you need to put into your internal education, I would invite you to ask the identical question or a variant of the question based on my response to the email addresses that are included at the end of this presentation, so you get something in writing and implement it as policy or education in your facility. Next slide, please. It's surprising to me, maybe not to you, that we have gotten dozens and dozens of questions saying, can we use the 95-97 with the 2021? Okay, so I think that question comes from the root cause of in the old days we said that you could use the 95-97, you can use them interchangeably, but those no longer exist, right? The only table or the only coding guidance and billing guidance that you can use is 2021. I do see a question was asked. I don't know. It's basically saying, can you tell us a website? And the short answer is yes. At the end of the presentation, we'll tell you the website. But anyway, getting back to this slide, 2021 are the only risk management, the only guidance that you're allowed to use in coding and billing for these services as of January 1st. Next slide. Again, next slide. This is the a broader, again, this is exactly from CPT AMA with a website, and this is a decision-making grid that is pretty clear. I mean, I think it's pretty clear. And on the same site, they go through some scenarios. So I'm sure that yesterday and each practices, this is already April. So by now, I'm sure every practice, and I'm sure ASIP has done extensive education, knowing the organization the way I do through LACS. I am sure that you've had extensive educational opportunities to discuss all of these different components, excuse me, all these different components of the decision-making grid. So I'd invite you to look at this, and if there's questions, that are not found in our FAQs, or if you just want CGS's opinion about this grid and how to implement it, we're happy to do so. But, I really believe that most people, if they spend a little bit of time doing the research, it will be imprinted on their brain how to do this and implement it into their practice and to change their templated medical record to be more consistent with the 2021 guidance. Next slide, please. Okay. This is what I said, pulling forward chronic conditions. Now, this is a polite way of saying, I hit when the patient comes in, my medical assistant or my office staff pulls up the template for that visit, and part of that template is a listing of past medical history that have been part of the problem list ever since the patient filled out our form on day one of the visit, day one of their involvement in our practice. So in the old days, when I first went to medical school and we were dealing with paper medical records, on the left-hand side, when you opened up the flap of the medical record, was a problem list. And it was incumbent on the doctor to keep that problem list up to date. And there was a column that said, is it active? If it's inactive, when did it become inactive? If it was an acute problem, what are you doing? Like, so acute cystitis, antibiotics prescribed. I mean, that was part of your routine documentation. And that was a living, like a curriculum vitae is a living listing of what you have accomplished. It changes day to day based on what you are accomplishing. This was a living problem list. In today's world, and especially prior to 2021, there was a big emphasis in the electronic medical record of having a problem list. And you could hit either dot phrase, dot PMH or dot problem. And all of a sudden this, 20 or 30 things would pop up. Well, again, this is all about problems addressed. So if you see here the answer, and again, here's a reference, noting chronic conditions that another specialist manages do not qualify. Now, even if you're the one managing that problem, I'm sure patients come in and have a multitude of problems and multitude of things on their chronic problem list, but they're coming in for one specific reason that day. So if you address those other problems, or if those problems are part and parcel of complexity, or part and parcel of management, and part and parcel of how you're going to take care of a patient that day, you got to document that. Just having a list there, as opposed to the old days, no longer helps you. No longer helps you unless those issues are part of management. They no longer help you in deciding the level of service. So the eggs in a basket concept that was implemented by coders, billers, and electronic medical record programmers no longer exist. When I'm saying they don't exist, I can't tell you what to pull forward, but they no longer exist unless it's part of a management and addressing the specific problem on the list. Unless you do those things, they're not involved in level of service determination. So I know I've said that 20 different ways, but I want to make sure that it's really understood that the long list of chronic problems, past medical history, et cetera, really is no longer needed every single visit. I quite frankly have always questioned the need from a clinical standpoint. Why do I need to pull 40 problems when I'm dealing with back pain? The fact that he had a bunionectomy, 25 years ago and are not having any complaints in that area. I'm not sure why I have to have that every single visit. The first time it's important because that may alter their gaiting, be a problem with their involved problem with their back pain. But every single visit to pull that up, part of a template, I've always questioned the clinical use of that. But from a level of service standpoint, those long lists no longer count. Next slide, please. Okay. This deals with, can you give an example, moderate versus high, dealing with cancer? Now, again, this is the exact question, and I want to make sure that this can be applicable to what you do. So the key words of complexity are problems addressed. Cancer has different variables, type, stage, etc., with comorbidities. So therefore, moderate, undiagnosed new problem with an uncertain prognosis. High, any kind of acute or chronic illness posing a threat to life or bodily function. So if someone comes with cord compression, right, due to a metastatic tumor, that's a problem, because if you don't treat that immediately, that person's going to have a big problem. They're going to have permanent disability, and if it's metastatic to the spinal cord, obviously the acute nature of that and the aggressive nature of taking care of that and getting them to an oncologist and other aspects is very different than someone that comes in saying, I have low back pain, and your assessment and decision-making, all that stuff rounds out to just being a functional sprain or strain of a muscle. So, the table of risk dealing with moderate and high complexity has to be decided based on, what is involved in the management of the patient. And it cannot be decided really until you've completed your visit. Because when a patient walks in and says, I have back pain, of course, you pull up your differential in your brain of anything that could be causing that back pain. But once you ask a couple of questions, the red flags of cord compression, I'm sure go away very, very quickly. So again, these are issues addressed, things that are part and parcel of the management of the patient that go into the complexity of the care once you go through the process. Okay. Next question. This is germane because I know y'all do a lot of less now than before, I'm sure, but y'all are involved a lot with pain, pain medications, and I'm sure that y'all manage it, dealing with looking to see are they taking their pills and who else is giving them their pills and all the different things that go into management of pain, pain medications. So here's the question: if I have my staff pull up an ORS to see what they're taking, basically, what is this, right? So if the prescription history is intentionally requested and used in decision making, then it's an external review from a unique source. If it's routine order per state requirement, then it would not be. Now, what does that mean? So there are some practices that every time the patient walks in, they get an ORS and a urine drug screen, right? So, a lot of that has to do with state mandate. You have to check this. To be very honest, all the state mandates say you should check a drug screen and the ORS as frequently as necessary to manage a patient. Some people have interpreted that to every month, regardless of the scenario. But if it's part of a routine and you don't comment how you're utilizing that results, you can't use it as a unique source external review. If, however, the patient comes in and they're here for a visit, and part of your management of the patient is to know how many pills they're actually taking. In other words, if they come in saying the pain's no better, and the pharmacological, the pharmaceutical report says you gave them 14 pills with one refill, let's just use that as a scenario, and they come in saying that they haven't gotten a refill and saw them at 30 days and they're saying my pain is unbearable, your question is going to be, have you been taking the medicine as prescribed? And if they haven't gotten a refill, then there's no way they're taking it as prescribed. So that will be part of management. So again, the ORS check has to be part and parcel of the management of the patient, not just a routine. Those of us who have been in Medicare more than a day understand Medicare does not like anything that's in quotes routine. By routine orders, standing orders, routine orders. Medicare has a problem with that. And the reason is because medical necessity requires that any order or any procedure, any prescription, any data analysis, all those different things have got to be involved in the care of the patient. So therefore, if all you're doing is doing it as part of a routine and there's no comment about how you're using it, other than a templated note saying ORS was reviewed, that is not counted in your data reviewed and analyzed. Next slide. This is the same thing as ordering a test. What does ordering a test in the category of test results and review of test results and not a subsequent encounter mean? I've seen people interpret this many ways. How do we count it? So CGS will not be counting items to fulfill a selected code. We don't put eggs in a basket. We never have, and we don't plan on doing that now. The focus is on care provided and clearly documented, as far as care of the patient. Now, how do we interpret that AMA statement of ordering a test? So the order and review would be included on the same date of service when choosing an E&M level of service based on decision making. So what that means is you can't count the test twice. So if you count ordering the test, let's just use a scenario. On January 1st, if I see a patient and I order a test and I count ordering the test and my level of service for medical decision making, that includes reviewing the results. So if I'm going to count reviewing the results when I see the patient 2 weeks from now, don't count it for ordering the test. So you got to make a decision, where in the decision-making process are you going to utilize ordering this test, right? Is ordering the test really the aspect of managing a patient, or is it going to be understanding, analyzing, and applying the results of that test to the patient that you're going to want to count? I would imagine, as an internist, I would imagine, for y'all as well, ordering the MRI, even though it is part of the care of the patient, is really a minimal, if you will, a minimal aspect of the care. What really comes into the care is when that results come back. Now, if your routine care pattern is to order the MRI on January 1st, and then you've had the patient come back 10 days later or 2 weeks later or whatever time frame later to review those results and discuss the next steps, I personally, and again, I can't tell you what to do, I'm speaking just personally, I personally would utilize the discussion, the analysis, and the implementation of a care plan regarding the results and everything else packaged into that. I would use that, which means the next visit, I would be using that as part of my decision making, because it's going to be, quite frankly, more important in the care of the patient. Ordering it's important, but actually utilizing the results and the care plan, in my opinion, would be much more significant and important. So that's just my personal opinion and how I would implement this particular aspect of the 2021 rules. Next slide, please. Major or minor. Again, I talked about this already. I'm going to go a little bit quicker because I see I'm getting ready to run out of time here. And I know Lax has said he's going to give me a little bit more time, but I want to make sure I get to your questions. Risk. I went through this already. Risk is in the eyes of the beholder. Someone with acute back pain going into the leg, is a completely different risk and complexity to you than it is to me. And that's because that's your expertise. Now, it doesn't mean that it's always going to be low complexity or low risk, but it will have a different characteristic in your hands than it would be in mine. Next slide, please. Okay, this is about cardiac catheterizations. To be very honest, I'm not sure it's germane to this audience. Next slide, please. Okay. This has to do with risk of death, probability or consequence of an event. So we talked about this already previously about if I give an injection or if I do a certain procedure on a patient, what is the risk? So the risk has to do in your hands or in the published literature, what is the probability of there being a problem? So I brought up about diabetic management. You know, y'all are injecting steroids all day, every day. And I don't mean that as a negative, but that's kind of what y'all do, right? When it comes to interventions. So in your hands and in your literature, that I'm sure many people in today's call actually wrote the literature, in your hands, the dose of steroids that you use delivered in the right place, what is the incidence or the probability of a severe diabetic or a complicated diabetic getting out of control? So again, in my eyes, that risk is significant, it's probable, and can end up putting a patient in the hospital. In your hands, you know, your experience, you say, based on the dose and my technique, I've had less than one patient in 5 years have a problem. So for me, I would define that risk as high. For you in your own hands, right, and the expertise that you have, you may say, no, this is really a moderate risk, not a high risk. So risk is in the eyes of the beholder. Next slide, please. This is an EKG, but we can apply it to you know, an X-ray or something like that. If you order a test, you look at that data in the decision-making grid to determine. So if a test or study, the last bullet point, is independently interpreted to manage a patient, but is not separately reported, which means you don't bill me for it, it's part of the decision-making. If, however, you do an MRI in your office or CT in your office and you bill me separately for it, and you do a separate report, so you bill me not only for the technical but also the professional, you do not include it in your interpretation or in your medical decision making, because it's a separate service, right? It says specifically identifiable, perform the data service may be reported separately. The actual performance during a patient encounter is not included in determining the levels of E&M services reported separately. So what that means is, like I said, if you do an MRI on the same data service and you separately interpret it, what that means is you file a separate report and bill me separately for that MRI. The MRI itself is not an independent aspect of your medical decision making. You can count that, you know, if you do it on a separate day and bring the patient back, that's one thing. Or if you do it on that same day and say, you know, let's start physical therapy, let's start anti-inflammatories, and when you come back, we'll go through how you're feeling and how the MRI looks like. So using that MRI on a separate data service, as we discussed before. But if you do everything on the same day, it's a separate report. That decision-making is bundled, if you will, but moved into that MRI report. You're getting paid for that separately. You cannot calculate that in the decision-making in addition. Okay, next slide. Basically, same thing. If we bill a service under our tax ID, do we count it as an order or a review? We can't do both. So a patient comes in and they get a lab or an X-ray. Can we count in the data as order of unique tests? When lab or imaging is performed and billed by your office, it cannot be included in an E&M service. The physician can choose based on other qualifying factors such as time. So again, you have to make a decision if you're going to do an MRI, CT, nerve conduction velocity, any of these kinds of things in your office, and you're going to bill that as a separate service. I mean PCTC, you know, or even you bill it on your same tax ID as a technical, you cannot count that for decision making. You know, coordinating it and all the different things could be included in time, but it cannot be added into your decision making. Next slide. So this is basically referral and having to discuss things. I think we covered this already about time. Let's go to the next slide, more germane to this group, this prescription drug management. So reviewing medication, determining what's correct, continuing a medication beneficial seems to be a service that would qualify as management. Can you review and clarify? So decision-making to adjust a medicine, addressing and managing a problem is a higher complexity than just saying continue sane, right? So we need to make sure that you give us very good documentation as to what you're doing. So if a patient comes in and they're on a group of medications and you say patient is stable, continue same medications, that's not the same complexity as saying the patient is having breakthrough pain, so I'm going to add such and such, or the patient is ORS was not consistent with their reporting, so we need to be careful about that. So you're adding a nuance, and you're not just saying continue same medications. So all that goes into decision making. It may not go into as far as time. So if a patient, if you refill medicines, remember hitting that button and having your staff set up for appropriate use criteria, and you hitting the button, sending it to the e-prescribing pharmacy, that's counted as time. But if it's a routine, refill, decision making is very, very low, and quite frankly, really should not be counted unless you discuss how that refill is used in the management and care of the patient. Next slide, and then we're done, and I'll answer some questions. I went a little bit slower than I thought I would, but I think I needed to make things clear. Okay, clarified drug management. It appears from the Q&A that this would only involve increasing and decreasing medicines. Clarify how a refill is used. So only documented reviewed does not support management. Okay, so we see medical records all the time saying, prescription drugs were reviewed. Okay, so how is that managing the patient? Right? It really isn't. It's just saying that you looked at it. And often, we'll just leave it as you looked at it. Okay, so you got to be very clear, whether you just refill the medicine or you adjust the medicine, how you're involving that, not only from an addressing it standpoint, but also from a management of the patient. So those are very key factors. So next slide. I'm not going to be speaking to this whole next section, but in here deals with the cert error rate. It deals with, our reviews and different things. Please look at it. If you have questions or concerns, please let me know through the email addresses that are in this, the second half of this presentation. Max, I'm going to stop now. There is a question I see in the Q&A box. I'm going to look at it. This is from Marcus Polk. Would a prolonged service code be appropriate for complex follow-up patients that subsequently receive simple office-based procedures such as trigger points on the same day and directly after the visit? Of course, the total adds up and qualifies. So again, the prolonged service code is something that you personally decide based on the time, that you require to take care of that patient. I know that Lax is going to be answering that in his presentation as well, but you decide on that time. Complexity and things of that nature. If I review the chart and you say, oh, I spent 90 minutes and there's only 2 sentences in the chart, that's a problem. So the short answer to it is if you took the time and you believe it's required and you document the care management and everything else that's required to take care of that patient, then you could use that. All right. Roland Chalifo. I don't know if I mispronounced that. I apologize if I did. I'm confused about ICD-10 problems we find on a patient when we first see them and how they will be approached over time in our office. They have, in many cases, morbidities, etc., and different axial pain locations. I like keeping that initial list in case of exacerbations. Are you telling us to remove it or just discuss the IDs? No. Remember, I told you, don't remove it if you use it, because just like you say in your question, Roland, you may want to reflect back if someone has a problem. What did they tell me on that first day? What I tried to convey, and obviously I wasn't as clear, concise, correct, and considerate as I should have been, but what I tried to say is when it comes to eggs in a basket or it comes to counting up problems, in today's world, 2021, the problems on the problem list can only be counted if you actively address them or you document in your decision making how those problems interact for the management of the patient on that date of service. So I'm not telling you to remove anything. You practice medicine the way you practice medicine. I can't tell you how to do so. I'm telling you that the long list of problems that in the old days were added up as eggs in a basket and went into your level of service determination, that aspect of it no longer exists. So I hope I answered your question. Are there any other questions
Thank
I
you.
can answer?
Thank you, Dr. Berman. One of the questions we have is that on the definition of chronic, that is the meaning since the duration of the onset of pain or a problem or expected duration, how long it will last. Like we
So,
define chronic pain as something lasting for something over 3 months or 6 months based on each individual definitions. But then AMA says it has to last 1 year or so. People are interpreting that pain should have been there for 1 year to consider it is chronic. That is incorrect, right?
that is incorrect. The chronic means that this is a problem. Let's just use low back pain. This is a problem that is expected to last a year, whether I intervene or not. In other words, if someone has low back pain and based on your assessment, you are going to classify it as a chronic low back pain. That means that in your expert opinion, this is the type of back pain that's going to be around for a while, as opposed to someone who comes with an acute muscle strain that, when handled properly, is going to go away in 6 weeks or 12 weeks or whatever it would be. So that's what you touch on is exactly why y'all are experts. The expertise deals with, in my expert opinion, is this the type of problem that's going to be around for a while? And a while means 12 months. Now, if it goes away in 11 months, no one's going to say, give me all your money back. But you would make a statement, that this type of pain is classified as chronic back pain. And I'm going to be doing the following things to try and alleviate for this patient.
That is the way AMA defines the permanent impairment. If you expect it to last longer than 1 year, they call it permanent, right? That is what I remember.
Well, that's an ADA. That's a whole different area.
Right. But I'm just saying the same philosophy here. So my next question is related to this prescription drug management. Now, prescription drug management, we are dealing with opioids and anti-inflammatory agents. And these patients are on benzodiazepines, even though we try not to give them together. Some of them are on stimulants. So there is multiple drug therapy here, and multiple physicians are involved, and they go to the emergency room or they have a surgery done. So this may look like a routine check of the drug monitoring program, but there is a lot of important information there. And people should not be doing routinely drug testing every month. We are totally against it. And there is no need to see the patients even every month either, except if you are doing a Suboxone MAT or there is a problem with the patient management. But if we are seeing for patients for management every 2 months, let us say in a hypothetical situation, so we are checking their the drug management profile and assessing their risk and adjusting or refilling the medication. If there is no adjustment and it is only a refill, but we are also looking at all the other issues. There's smoking, depression, bipolar, schizophrenia, all these interacting factors, sleep apnea. So these things, that should increase the risk to moderate, right? Or
Well, so the answer to the question is, what do you do with the information? In other words, I'm sure based on what you stated, you've seen our, drugs of abuse LCD. We like to have a risk assessment before you just routinely refill opioids. And I know with your expertise and involvement in all of our LCDs, you're very aware of them. But in your comments about you don't need to see them every month is 100% right. But if you're looking at all of that stuff and you don't comment on it, how do I know that you looked at it? So what you're saying is if you say, patient is on benzodiazepine, again, I'm making a statement, and don't take this as something that must be documented in the exact fashion that I'm saying it. But if you comment, patient is on multiple drugs whose interaction can cause significant problems, I am refilling because they need these drugs as part of the care plan or something like that. No, there must be a comment somewhere, somehow, as to those aspects you just mentioned. They have sleep apnea, they have COPD, they're morbidly obese, they're on benzo, they're frequent ER visitors, they have polypharmacy. Just to say, ORs reviewed, medicines refilled, that doesn't count as anything. Because remember, the complexity and all those things are part of the medical record that show interpretation, management, something that's being addressed in the care of the patient. Just saying, I reviewed the labs, or I reviewed the ORs, or I reviewed the past medical history, and I'm doing the same thing next time. How does that show me decision making, right? I mean, that I'm answering it that way for the audience. There's 67 other people out there listening that may not want to, really may not want to put a sentence or two in there that changes review into a decision-making aspect by adding a couple of sentences showing how it's going to be used to address the care of the patient. So what you said is right if something is documented in the chart showing that all of that was considered. Does that make sense?
Yes, sir. And a lot of our patients have multiple regions involved, like neck pain, low back pain, and mid back pain, but then they also have knee pain. They also have depression. We are not actively managing. Sometimes we do manage it. They have anxiety. Sometimes we do, sometimes we don't. We can list all those things, I think, whatever we are actively managing, if I understand correctly. If we're not managing them, then they are dormant there. But if you stop their treatments, those issues can become significant. So we can list those things, those conditions.
Well, I'm happy for you to list anything that you want to list. What you can count towards decision making are only the things that you address in the care of the patient. So you're right. I mean, knee pain or a history of a meniscectomy or a history of knee replacement, that's something that's very important for you to understand and know, and how it impacts on the patient's back pain. But if you're not actively commenting on it, then it's not really counted towards decision making. So I want to be very clear, because this is now the second time this has been brought up. I am not telling anyone to no longer keep a problem list. I'm not telling anyone not to list the 200 medical problems of the patients that come into your office. I'm not telling you not to do that. What I am telling you clearly, and I'm sure there's going to be some sort of document of today's lecture, I am telling you clearly that in order to count anything on that long list of past medical history or past surgical history, is they must be addressed and they must be part of the management of the patient on that date of service. If you do not comment or document either of those things, nothing on that long list will be counted towards medical decision making.
Yeah, that is the key word you said, addressed at that encounter. So if we are not addressing at that encounter, they don't mean anything, whether you list or not.
Addressed and part of the management of the patient that day.
That's right. Okay. Well, thank you very much. And we really appreciate the meeting and your lecture. It was awesome. So again, we will talk to you later again. Thank you again.
Absolutely. Thank you so much. And everyone have a great day. And I look forward to hearing comments and questions about today's talk. Thank you again.